Hello, I'm Sateria Venable, founder and CEO of the Fibroid Foundation. Welcome to Fibroid Awareness Month 2023. Today, we will be discussing fibroids and menopause. We will discuss how to navigate perimenopause and menopause when you have fibroids. Do the fibroids go away? Do they shrink? What effect does hormone therapy have? Today, I'm pleased to interview Dr. Lauren Streicher. Dr. Streicher is a clinical professor of obstetrics and gynecology at Northwestern University's Feinberg School of Medicine in Chicago. She's a fellow in the American College of Obstetrics and Gynecology, a member of the Sexual Medicine Society of North America, and the International Society for the Study of Women's Sexual Health. Dr. Streicher is a keynote speaker, a trusted source on national media, and an author with 4 best-selling books. She is recognized as a reliable, accurate source both locally and nationally. And I personally have admired Dr. Streicher's expertise for quite some time, having lived in Chicago, and I'm thrilled that she is joining us for Fibroid Awareness Month. Welcome, Dr. Streicher. I am so happy to see you and to have this important conversation on menopause and fibroids.
And it is my pleasure to be here chatting with you about one of my favorite topics, menopause and fibroids.
It's one of my new favorite topics. And I think that you are like, when I think about the combination of the health concern of uterine fibroids and menopause in general, I automatically think of you because you treated patients with uterine fibroids for so many years. And I remember wanting to see you and just everyone utilizing your skill sets as a resource in Chicago. You were always on the top doctor list. And now that you have so much information to lend from that experience to menopause with your podcasts and your books, and just the clarity of the information that you deliver on the podcast, I'm I encourage all of you, in addition to listening to this today, check out Dr. Streicher's podcast because you will learn so much. And I've spent the past 3 years really researching menopause sources, and she's at the top of the list. So
I appreciate your kind words. And one of the things that's so unique about this topic is not every woman has fibroids. A lot of them do, but not every woman has fibroids. But 100% of women will go through menopause. So this is such a relevant topic, not just to your audience, but to women everywhere.
I couldn't agree more. And so we reached out to our community and asked them what was on their minds in terms of their fibroid journey in relation to perimenopause and menopause. And so I have a few questions for you. You ready? You're always ready.
I am ready.
Okay. All right. The first one says, help. Does that sound familiar?
Help. This is how most questions. Now, most questions start off, my friend wants to know.
Oh, okay.
Usually those are the sexual ones.
I see. I can see that too.
Or help.
Yeah.
Help. I need help.
Well, this one says help. Radiating heat, hot flashes, 36 years old, had a myomectomy last year. And what do I do? Because I'm hot as I can be.
Well, at 36 years old, the first thing that we need to figure out is, are the hot flashes a result of an early menopause, a premature menopause, what we call ovarian insufficiency, meaning the ovaries are winding down, or something else altogether? Because myomectomy, of course, is removal of fibroids, but it should not impact on hormones, because the hormones don't come from the fibroids, they don't come from the uterus, they come from the ovaries. So if nothing was done to the ovaries, and if the uterus is still intact, then a myomectomy in and of itself does not increase the likelihood of someone entering an early menopause. So step number 1, are those hot flashes, night sweats, feeling miserable? Is this because estrogen levels are very low, or because there's something else going on? Sometimes it can be a thyroid problem. Maybe it's another medication. Was this woman given a medication such as Lupron or one of these similar medications that can cause menopause symptoms? So you can't assume that it's the myomectomy, and in fact, quite the opposite. We assume it's not the myomectomy. But the first step is to figure out, is it low estrogen, or is it something else? And while I'm not a huge advocate of getting hormone levels routinely, this is the exception to that rule. Because if you have a woman who's 55 and hasn't had a period in 5 years, she does not need a blood level to tell you that her estrogen level is 0. But when someone is in their 30s and they're having symptoms that may indicate an early menopause, then that is a reason to get some hormone levels, an estrogen level, an FSH level, which is follicle stimulating hormone, an LH level, which is luteinizing hormone. These are pituitary hormones, and that will be your first clue as to what's going on. If in fact this woman is going through a premature ovarian insufficiency or premature ovarian failure, which we commonly think of as premature menopause, then in general, depending on her medical history, hormone therapy is not only an option, but it's critically important, because we know that women that go through an early menopause before the age of 40 are at particularly high risk for long-term problems such as bone loss and cardiovascular disease. But we need to figure out what's going on with this woman before we can really help her.
And so should that testing be done through labs or another method?
Yeah, the first thing to do, of course, is to get some blood work done. And one of the things that she didn't state in her question is if she's still getting periods. And if she is still getting periods, then sometimes you need to do those labs more than once, because we know that these hormone levels will naturally cycle depending where you are in your period. So if she's not getting periods, so I'd want to know a little bit more about that. When did she last get a period? How often was she getting a period before that? Is she having other symptoms such as vaginal dryness, pain with intercourse, bladder symptoms? So there's a lot of information we don't have here in terms of really knowing what's going on. But yes, we do start with a very thorough history and then some blood work.
Okay, that's great feedback, and I'm sure that that community member will appreciate that, and it gives her some concrete next steps to take to find out more information. So thank you for that. Our next question is, I'm considering a uterine fibroid embolization instead of a hysterectomy. Can I still take hormone therapy? I'm 49 and in perimenopause.
The answer is yes. There's no reason based on the embolization that you can't. Now, as I assume this woman is already aware, the embolization in and of itself might push her towards menopause, particularly in women who are already perimenopausal, meaning that ovarian function's already starting to wind down. During the process of an embolization, the teeny tiny little beads that do their work, do what we want them to do in terms of blocking blood supply to the fibroids and therefore shrinking them, can also block blood supply to the ovaries. So we do know that women sometimes will go through menopause a little earlier than they may genetically be destined to do so based on the embolization. And there's absolutely no reason based on the embolization alone that she cannot take hormone therapy.
Okay. And this next question ties into what you just said, which is, after hysterectomy, is it likely to have an earlier menopause? How much earlier?
Well, we used to say no, but now we know that the answer is maybe. And really what this comes from is, as I said earlier, removing the uterus doesn't change your hormones. We know it doesn't change your hormones because your hormones, your estrogen and your testosterone and your progesterone are all coming from the ovaries. And obviously, if you remove the uterus and you leave the ovaries intact, reason would say, that's not going to change my hormone levels. But in fact, we know that in some women, it actually does push them towards a slightly earlier menopause. And the theory is that in the surgical process of disconnecting the uterus from the surrounding structures, that the blood supply to the ovaries may get slightly compromised. But in general, we are not talking dramatically earlier. We're talking perhaps a matter of months earlier than someone might. If someone is, it's so interesting to me that very often a woman will end up having a hysterectomy in her mid-40s for the reasons that we talked about before, and you're so well aware of, is at that point someone's done with their childbearing or wanting to maintain that opportunity, yet they're still having terribly terrible symptoms from their fibroids and opt to get a hysterectomy. And then when they go through menopause the next year, or even shortly after, they say, well, it was a hysterectomy, when in fact that just may have been when they were genetically destined to do so. But having said that, we do know that there are statistics that show that women who have a hysterectomy with preservation of the ovaries tend to go through menopause slightly earlier than they were destined to do so.
That's very helpful as well. Our next question is it a myth that fibroids shrink during menopause? If not, how fast do they shrink during menopause?
The answer to that question is it's a partial myth, meaning that it depends on the fibroid. We know that the larger the fibroid, the less likely it is to shrink, which is so unfair because the women that are suffering with bulk symptoms, the huge fibroids that are pushing against their bowel and their bladder, those are the women that are the most hopeful that when they go through menopause, that those large fibroids are going to shrink away to nothing, when in fact, while there is some shrinkage, they're not going to disappear. It's the little guys, the little teeny fibroids that can be so troublesome prior to menopause, that are in the lining of the uterus, that very often will shrink away. And quite frankly, at that point, it doesn't matter because you're not menstruating anymore. So you ask why? Well, the reason generally is the large fibroids have outgrown their blood supply already. Maybe they become a little necrotic, meaning the tissue isn't viable anymore. Maybe they've even become calcified, meaning that they're actual calcium deposits that make it kind of a hard rock-like fibroid. And at that point, changing your hormones is not going to change the size of that fibroid. So it's a little bit of a myth, but not always a myth.
And thanks for clarifying that, because I think there may be perceptions that fibroids just evaporate, and that is not.
Well,
No.
part of that also, quite frankly, is I blame physicians. Sometimes physicians will tell women that. They will say to them, well, you don't need to have surgery. You don't need to do anything because you're close to menopause. And when you go through menopause, it's all going to shrink away and your problems are going to be gone. And that's true if bleeding is someone's problem. But if someone's problem is bulk symptoms, that is not necessarily the case, yet they're set up to believe that those symptoms are going to disappear.
That's huge. And I don't think we discuss bulk symptoms enough. And oftentimes people don't know what they are. So Dr. Streicher, would you let our community know what bulk symptoms are?
The bulk symptoms are basically any time that the fibroids become so large that they press on the organs that are surrounding the uterus. Because keep in mind that the uterus is happily settled in the area behind the bladder and in front of your bowel, in front of your rectum. And that's where it's supposed to go. But keep in mind that a uterus without fibroids is about the size of a pear. A uterus with fibroids, as you know, can be enormous. You can essentially have the size of a basketball or even larger, and something's got to go. It's going to be pushing on something. So bulk symptoms refer to when your uterus is pushing on your bladder. And when that happens, the symptoms that you're going to have are frequent urination and constant pressure on your bladder, even if there's no urine in the bladder, even if you don't have to go. Sometimes women will even become incontinent, meaning that they'll have involuntary loss of urine. Urine will just suddenly come out, even though they don't feel like they have to urinate and they haven't pushed down to urinate. And then it can also be on the other end because it's fibroids on the front of the uterus that tend to push on the bladder. But if you have a fibroid that's in the back of the uterus, it can push on the rectum. And that can cause that feeling of pressure in the rectum, like you have to have a bowel movement even when you don't. In some women, in extreme cases, they may even have difficulty having a bowel movement. They might have a lot of problems with constipation because that large fibroid is actually an obstruction to the stool being able to come out. And some women, their bulk symptoms are really just in terms of size. We've all seen the woman who's pregnant, who looks like, let me start that. We all see the woman who looks like she's pregnant, but she's not, because essentially her uterus has grown to the size that it would during a 9-month pregnancy. But instead of a baby inside, it's a big old fibroid inside. So those are bulk symptoms. And while bulk symptoms in general are not as serious as women who have bleeding because they don't result in anemia, they don't result in a life-threatening situation where someone's blood count drops so low that it can impact on their heart and on other vital structures. but it can be incredibly, incredibly uncomfortable. And keep in mind that some women have both bulk symptoms and bleeding. That is not unusual, but you can have just one or the other as well. And a lot of women are surprised to learn they have a fibroid because they might have very light normal periods, and they go to the doctor thinking that there's something wrong with their bladder because they keep having to go to the bathroom, and then on exam find out that a fibroid is actually pushing into the bladder.
You touched on a lot of things that I'd like to highlight. One is that I think a lot of us suffer through bulk symptoms, not knowing what they are and thinking that we're the only ones who are struggling with that. So I am certain that that response that you just gave is providing some relief to many of our listeners. I had a fibroid. The main fibroid that just caused me so much angst was 7 to 9 centimeters at any given time, sitting directly on top of my bladder. And, you know, those symptoms just result from that pressure and that in that tight space as you described. So,
And it's constant. I mean, this is no small thing. There are women who literally cannot get through their workday, teachers who can't stay in the classroom because they feel like they have to go to the bathroom every single second. And I'll never forget one woman who came to me and told me she was doing 200 sit-ups a day and she did not know why her belly wasn't going down. And she was a normal weight and she was healthy in every way you can think of, except she had a basketball sitting in the front wall of her uterus from her fibroid and had absolutely no idea.
Absolutely. And I know we're talking about menopause today, but you also touched on anemia. And I think I know for a fact that the danger that anemia can present is not often emphasized enough. And this whole journey has been started with me observing what was happening with my body and then getting input from community members who were having similar journeys. And I remember having a hemoglobin of 5.6 when I was 36, and then having a hemoglobin of 6 in my 40s. And it took a much larger toll on my body. My body was not equipped to handle losing half of its blood. My heart was racing more. It was just, everything was completely off kilter. And when fibroids are described as benign, which I prefer the word non-cancerous, because if you lose half the blood in your body, it's not something that's benign. It's very,
No,
very,
it's not
very
benign at
serious.
all. And to your point, the anemia thing is very, very different for young women with fibroids than it is for someone else. So as an example, if you have a woman, common scenario, she has a baby and she has a big postpartum hemorrhage, you know, severe bleeding after a baby. Well, she's going to drop from a hemoglobin of 12 or 13, which is normal, to a hemoglobin of, say, 6 or 7 very quickly, and is going to be very, very symptomatic because it was such a rapid drop. But when you take someone who has fibroids, this is a gradual decline in her blood count, and a young, healthy woman will accommodate. So if you take someone who suddenly goes from hemoglobin of 12 to 6, well, they're going to know it. There is no question. They're going to pass out. They're going to be faint. They're going to be exhausted. But if you take someone who over the course of 5 or 6 years goes from a hemoglobin of 12 to a hemoglobin of 5 to 6, they may not realize it. It's so gradual that they, first of all, think it's normal to be tired. They think it's normal to get short of breath. They think it's normal to feel weak when you walk up a couple of flights of stairs because it's such a slow, insidious onset. And you think, how could someone not know it? How could they not know that they've lost half their blood volume? It happens all the time. And then someone comes in and we might do a routine blood test and find out that their hemoglobin is ridiculously low like yours was. And I'll say, aren't you tired? And you're like, no more than usual because you're used to it. And I think the one thing that I learned as an older doctor, quite frankly, from being a younger doctor, is listen to your patient. If they say, you know, I am kind of tired, take that seriously. Don't just brush that off as, well, of course women are tired. They're working hard and they have kids and they're running around, you know. Pay attention when someone says, I'm tired, get that blood count. And when someone says, if you find out someone's very anemic and you say, well, are your periods heavy? And their response says, well, they've always been heavy. Well, maybe they've always been heavy because they've always had fibroids and they're used to it. One person's normal is another person's hemorrhage. And we really need to figure out what's going on.
I wholeheartedly agree. In fact, as you were talking, I remembered that I used to slowly rise from the bed when I got up in the morning, because if I stood up too fast with the low hemoglobin, my body just could not handle it. So
And did you think that was normal at the time?
by that time, I knew it wasn't. But
Yeah.
prior to that, I had a hemoglobin, I think maybe it was like 8 or 9. And just as you described, my body had calibrated to handling that low hemoglobin. And
Yeah.
until it was pointed out to me, I didn't realize that I was taking very shallow breaths. Like
Yeah.
I wasn't breathing all the way down. I even tried to run a 5K and couldn't figure out why. I couldn't, get any air in. So
Yeah.
I think for us, most patients are non-physicians, and they need to, especially like, for instance, I have been told from very young, you're anemic, you can't donate blood. And I was like, anemic, okay, what does that mean? But
Okay,
I
like
didn't
it's
really
almost like
understand.
it's kind of normal. Like some people are
Yeah,
anemic, some people have brown hair, some
yeah,
people have
yeah,
blonde hair, some
exactly.
people are anemic. And no
Precisely.
one ever said to you, you're anemic, you need to find out why.
No, never,
Yeah.
never.
Yeah.
Mm-mm. So that's incredibly helpful. I'm so glad that we discussed that particular topic. So my last question is, will hormone therapy patches make fibroids grow? This particular community, some member said her fibroids were under control before starting hormone therapy.
Yeah. It's an excellent question, and it's a difficult question because the data is inconsistent. The overwhelming amount of data shows that it will not cause your fibroids to grow. And in fact, as you know, and has been pointed out, I'm sure many times in your programs, postmenopausally, even if they don't shrink, they certainly shouldn't be growing. And if they are growing, you want to check it out and find out why. So the question always is, if someone is in menopause and they start hormone therapy and their fibroids are growing, is it the hormone therapy or is it something else? And this is particularly true if someone is bleeding. So as a sweeping generalization, what I would tell women is fibroids in general do not appear to grow with the use of a low-dose menopause hormone therapy, which is what we're doing. Menopause therapy is very low dose. It's not like taking higher dose birth control pills. And that if you are postmenopause, whether you are taking hormones or not taking hormones, if you are bleeding or if your fibroids appear to be growing, don't assume that that's from your hormone therapy. You need to get it checked out because it may have nothing to do with your fibroids. And if your fibroids are growing, you want to make sure that it is in fact fibroids and not that extremely, extremely rare, but very serious condition called the leiomyosarcoma. And but most experts agree that it is perfectly fine to give hormone therapy to women who have fibroids. And when I say hormone therapy, I want to be clear, what we're talking about is systemic hormone therapy, either in the form of a pill that you put in your mouth or transdermal, meaning a patch, a spray, a cream that you absorb through your skin that will help hot flashes, sleep, cognitive function, your bones. This is not the same as using a local vaginal estrogen in the vagina or on the vulva to help with vaginal vulvar dryness or painful sex or urinary symptoms. That is not controversial at all. There is no reason that a woman cannot use a local vaginal estrogen.
That's helpful as well. So I have a follow-up question, Dr. Streicher. We often, when we think of hormone therapy, I think most people think of estrogen. And estrogen, there are certain types of estrogen that are FDA approved for hormone therapy. Do you see on the horizon where there might be an FDA approved testosterone or progesterone, or how should our viewers go about exploring the precise
Yeah.
needs that they might have for hormone therapy?
Yeah, well, I'm so glad you asked that because there's a lot of confusion about an FDA approved product versus something that one buys from a compounding pharmacy. So when it comes to estrogen, yes, there are a number of FDA-approved estrogens, both bioidentical and synthetic estrogens. There are also a number of FDA-approved progesterones, which we give for women who have a uterus to protect the lining of the uterus. And in fact, I have a podcast that just came out about a month ago, looking specifically at all of the progesterones, the different types, the pros, the cons, and which ones to use. Testosterone is a different story. Testosterone is an interesting story because there is no testosterone product that is currently FDA approved for use in women, and we don't expect it to happen anytime soon. And the reason for that is that there have been a number of times that testosterone for women have been developed, because we know that there is good scientific literature that in some women, particularly postmenopausal women, the testosterone is safe and effective in treating libido. And there was a product that tried to get FDA approved about 15 years ago, and it was called the Intrinsia patch. And before that was Libigel. There have been a number of products, and they never made it to the gate, meaning they never got the FDA approval, not because they detected any problems, not because there were any dangerous side effects, but because the FDA made so many requirements to get it approved that it became prohibitively expensive for the company. At the end of the day, pharmaceutical companies are in the business of making money. And when they say, okay, it's going to cost you another $50 million, and I'm not just making that number up, it's going to cost you another $50 million to maybe get FDA approval of this product in another 10 years because we want to see what the long-term results are 10 years later, the company basically said, I don't think so. And they abandoned. So do I prescribe testosterone for women? Yes, I do. I prescribe it off-label, meaning I'll use a pharmaceutical grade testosterone, which is intended for men, but I give it in different dosages for women, or I do get it from a trusted compounding pharmacy that is made up to the percentage and dosage that I want to administer. But obviously, this is something that needs to be done by an expert. And I do have a podcast episode called Say Yes to Testosterone, and it goes through all the specifics, but don't hold your breath for an FDA approved testosterone. And while I mentioned that compounding pharmacies can sometimes be very problematic, and I don't recommend them routinely, I do use them for products that cannot be obtained through a standardized commercial testosterone, through a standardized commercial pharmacy. But you do need to know what you're getting, and the person who's prescribing it needs to know what they're doing. And the last thing I'll say on testosterone is do not get a testosterone pellet. These are dangerous. They are unregulated, and we are seeing many, many problems with them, including an increased risk of uterine cancer.
Thank you for clarifying that. I appreciate that response, and I agree. So hopefully that your response that you just gave is information that I struggled to find for a long period of time. Mm-hmm. So I appreciate you just giving us the background as well. It also frustrates me that women's health has so many hurdles, for us to care for ourselves, for us to have been included in clinical trials consistently. There continue to be hurdles that just wouldn't happen if men were suffering like this. It just would not even be a discussion.
Well, you and I both know that that is absolutely the case. And a lot of women are not aware that the majority of scientific studies that have been done, even if they're done for drugs that are taken by women, they were only done in men. And not only that, but even if we look at trials that do include women, too often they only include white, thin, healthy women. Well, that's not what the world looks like. That is not what the United States looks like. And one of the things that people really have to pay attention to when they look at these clinical trials is who participated, who were the people that were representing the people in these clinical trials. There's a new hot flash drug that just got FDA approved. It's called fezolinetant. The trade name is Veoza, and it's a non-hormonal drug for hot flashes. And one of the things that I applaud the company for is that in the clinical trials, they have just as many women of color as they do white women. They have women of all sizes, all ethnicities, so that not only could they look at the results as in total, but they could break it down to every single one of these groups to give us some real information about who it works for, who it doesn't work for, and are there any differences. But this is rare. That's the point, is this is not something you can take for granted. Most of these clinical trials do not include the wide range of women that exist in this country.
Yeah, I'm glad that you shared that as well. We were not involved in or any oversight or consulting for that particular clinical trial, but when we are involved, we do review the clinical trial design to make sure that there is that diversity and inclusion. And that's another very important point that.
And as you know, very often it is not. It's just not there. And you can assume that for an older drug, it's not going to be there. The new drugs are starting to pay attention. They're realizing that people are looking and it's important and they need to include that. But if you look at drugs that were approved 20 years ago, absolutely not. And and that's just in women's drugs. So if we look at drugs for things like high blood pressure or heart disease or diabetes, women weren't even included in those trials because the last thing they want is a woman who has raging hormones or no hormones, or might be pregnant, or might have anything else that goes on in a woman's life that could impact on those results. They're looking for simple, straightforward, and FDA approval. And the way to do that was have a bunch of white, healthy men.
Yeah, the thing I love about my job is that my heart is in the work and I get to uncover so much amazing information. The thing that makes me sad is that that women's health has been so neglected that there is so much work to be done.
Yeah.
So it's like a catch-22, but Dr. Streicher, I so appreciate you, and you always bring light and so much knowledge, and I've just always enjoyed speaking with you, and thank you so much for just sharing your expertise with us during Fibroid Awareness Month and always, and we look forward to speaking with you at later dates, and wish you a happy summer.
And thank you for having me.
Thank you so much. Thank you for joining us today for this important conversation. If you're facing a menstrual health challenge, you do not have to face that journey alone. We encourage you to reach out to us at fibroidfoundation.org. Throughout Fibroid Awareness Month, the Fibroid Foundation has hosted Plastics and Fibroids and Workplace Strategies for Menstrual Care and the Black Maternal Health Crisis. If you missed any of these informative conversations, you can view them on our website, fibroidfoundation.org. We look forward to continuing to share powerful, informative, and enlightening conversations with you. Together, we are making a difference. Thank you and be well.